Hello, everyone. I am Will Reiter, Education Program Manager at the Association for Frontotemporal Degeneration, and I'm pleased to welcome you to providing professional FTD care in community settings. As many of you know, the symptoms of FTD can be very different from other dementias. Even care settings that specialize in dementia care can find it challenging to provide care and support to those with FTD without adequate education or an individualized approach to care. Our presenters will speak about how their programs have been successful in supporting those with FTD and providing the type of person-centered care that those living with FTD deserve. Before I introduce our speakers, I'd like to offer just a bit about some professional resources that AFTD provides. If you don't know already, AFTD has a quarterly healthcare professional newsletter called Partners in FTD Care. On the current slide, you have a link for the newsletter webpage. And I also am highlighting just two of the more than 20 e-newsletters that are available to you. The first one is specifically called Finding the Way, Successfully Transitioning to Residential Care. And the second one is specifically a resource for healthcare professionals to provide a clear and better understanding of the complex world of the genetics of FTD. Additionally, you should know that AFTD began offering continuing education credit webinars live. I think it's almost about 2 years now, and we will have one coming up on June 20th, focusing on a collaborative approach to diagnosis and treatment of FTD and ALS. It's not currently being promoted on our website, but you will likely get an invitation to that or be able to view the information on our website starting next week. And then finally, know that our helpline is definitely available and happy to respond to questions from healthcare professionals as well as family members to ask questions, to get more information, to be sent free resources for either yourself or for the families that you serve. I am going to now just acknowledge that this session is targeted to healthcare professionals, but if family members have joined us, we appreciate you being part of this session. I'm going to introduce each of our speakers individually. They'll provide a short presentation, and if possible, at the end, I'll invite them to come all back on screen, and at that point, we will ask any questions in the remaining time. Our first speaker, I'm pleased to invite and introduce Lindsey Vajpeyi, who is the Director of Early Stage Programs at Insight Memory Care in Northern Virginia. And Lindsey has dedicated her career to working with older adults who live with dementia and their care partners. She's a certified dementia practitioner, certified Alzheimer's disease and dementia care trainer. She has activity director certification with specialization in memory care, and is a master trainer with the Best Friends approach to care. I can see that Lindsey has joined us, so welcome, Lindsey. Take it away.
Thank you, Will, and hello to everyone out there listening in. I'll just give you a little bit of background on Insight so that you have more context to the comments that I'm making today in the session. Insight Memory Care Center is a nonprofit organization based in Northern Virginia, and we provide specialized care, support, and education to people living with dementia at all stages, as well as their family and the broader community. So our vision is really the highest quality of life for someone living with dementia, and we do that mainly through day programs for those individuals, as well as some wraparound supports for families. And so we have people in our programs with FTD, BVFTD, primary progressive aphasia, progressive supranuclear palsy, as well as Lewy body dementia, Alzheimer's, vascular dementia, and others. And so in addition to the stimulation and socialization and care that our day programs provide for the people enrolled, this is also some ongoing, regularly scheduled respite and an enhanced care team for the families of those loved ones as they are aging in place. So I've been working in this field for nearly 20 years now, and I would say even in my own experience in the first many years of my career, there is minimal training around FTD in senior care community settings, whether day programs, assisted living communities, skilled nursing, or otherwise. There tends to be more training around Alzheimer's-like symptoms, so understanding, caring for someone with Alzheimer's disease, but FTD sometimes gets, might get a comment or two, maybe a highlight of a few typical symptoms, but not often much more depth than that. And I think as a result of that, there are a lot of communities, whether day programs or senior living communities, that are very hesitant to have someone living with FTD join their program because the community is not feeling confident in being able to care adequately for the person and how they are going to integrate with the other people in that setting. So one thing that I think is really important when we're considering training for our team, which is essential, is also knowing the subtype of the individual living with FTD that's joining the program. So at Insight, for example, we are doing initial training with our team. For us specifically, we have all of our team members go through the Certified Dementia Practitioner program, but there's also ongoing training. And if someone is joining our day program, we are collecting as much information as we can about that person before they ever step foot through our door. And we're talking about that as a team. So really wanting to understand the subtype that the person has, the symptoms that they're experiencing, the ways that their family or other caregivers are supporting them, as well as a lot about their life, their lifestyle, their history, their routines. And I'll talk more about that in a minute. But with the training, this really needs to be something that incorporates all members of the care team and kind of the broader team, anyone who's going to interact with these individuals. So that could be, of course, nurses and caregivers and activity or recreation staff, social workers, but also your front desk person. It's going to be your housekeeper. It's going to be your dining room attendees. Really everyone needs to have an understanding about some common symptoms that they might observe in this particular participant or resident, as well as some strategies, just at least some basic strategies to be able to support that individual. And we're always going to learn as we go, and we're going to have to adjust as we go, but we do want our entire team to be as prepared as possible to have a successful experience for us in our day program, for our participant, but also for the team to really feel confident and have the tools that they need. So beyond the initial training and learning about the person coming into the program, there's going to be some ongoing team training, right? There's always more to learn. And I know that in most organizations, you're sort of tight on time and we've got a lot of people to take care of, but we do need to focus some time and energy on making sure that our team has the information and the supports that they need. I would say in our experience caring for people with FTD, there is a lot of ongoing brainstorming and collaboration and a lot of creativity, a lot of having to kind of think outside the box. And some of the ways that we might support a person living with Alzheimer's disease, it's going to look different when someone has FTD. So many of you listening in today are probably healthcare professionals. And I think another piece that's going to be important for all of us is to create a culture of really working interdisciplinarily within our organizations and openly discussing challenges and solutions without any fear of judgment. Really helping our teams to work together, to work with families, to think outside the box, and to really provide the best person-centered care possible. And I'm going to come back to person-centered care, but it's really helpful to lean on any resources that are available to you. So that might be an FTD specialist in your area. You might know of a specific provider who is very knowledgeable and might be willing to come in and talk with your team, or to do even a video training or something with your team. There might be a consultant in your area that you could invite in. AFTD has amazing resources, and I'm glad that Will pointed out the partners in care, because I know that's something that we draw upon at Insight. Webinars that AFTD is putting on have been great. I know at Insight, we try to have a couple members of our team listen into the webinars and be able to take the information they're learning and sort of utilize it out on the floor with caregivers. So knowing who's passionate about this, who really understands, who are those movers and shakers and motivators even within your own team to be able to share information forward with those who need to know. And we use a lot of our kind of standing meetings to be able to touch base on how things are going for specific participants in our program, just to sort of stay on top of anything that might be changing. So that could be a care plan meeting, a stand-up meeting, or other times that you decide to gather as a team and really work together. So coming back to the person-centered care, this is really key to what we do at Insight, but to what I'm sure most of you are doing in your community setting. So when someone is preparing to come into your program, they're taking a tour, there's probably an intake process of some kind, some general preparations that are happening. We want to take note of any pieces of information that could be helpful to us as we are getting to know that individual. So learning the person's story. Where did they grow up? What did they do for their career? What were their favorite hobbies? What are their favorite things to talk about? Are there any pet peeves or any triggers that we need to be aware of as well? We want information about the symptoms the person has been experiencing, how the family or other caregivers have been supporting that person recently. What were the person's routines like at home, and how can we try to keep those as consistent as possible when they're coming into our setting? How does a person communicate with others? How do people communicate with them effectively? How do they do in a group versus individually? How about with stimulation in the environment, like noise or like music? Are there movement features to be aware of? How about ADL needs? So we're gathering all of this information to help us prepare for the way we're going to care for that person. And for us at Insight, that's from the moment that they get out of their car or the bus to come into our center, how we greet someone, how we're planning the activities of the day around, that person and the other people who will be there, the way that we provide care and any ADL support, also the way that we are preventing any challenging situations or responding to any frustrations that the person is experiencing. And we're going to keep adjusting and learning as we go. And the person is going to keep changing as well. So that's just, kind of part of how we all need to adapt to provide the best person-centered care. And so person-centered care really means that we are there for the person and responding to exactly who they are and what they need at that time. And every individual in your care is going to be different with or without FTD. So I'm going to share some examples of ways that we have adapted our day program. So for some of the individuals with FTD that we've served, and I'm changing names, of course, to keep the identities anonymous. So for Don with BVFTD, his anosognosia made him completely unaware of any symptoms that he was experiencing. And it created quite a challenge for the family to be able to kind of get him to agree to come to our day program. So what was successful for Don was to ask him to volunteer with us in the program. He's highly intelligent, very capable with communication, but one of the big things that he experiences is some difficulty with impulse control. So in the beginning, we tried to have him help another participant with activities, but that ended up not being very successful because of that lack of impulse control. And since Don really could fly through a lot of our cognitive programming because his memory, his intelligence, really were still so intact, we actually had Don start to create answer sheets to the kind of pencil and paper worksheets that we do as part of our program. And that gave him a real sense of purpose. And it also gave him something that he could focus on that wasn't impacting the other participants as much in the program. So, and it changes, sometimes things work, sometimes they don't, they might work sometimes. And so we're always kind of tweaking and adjusting as he changes and as we learn and try different things that we find successful or not. So another participant, John, who had primary progressive aphasia, really enjoys participating in art-based projects and especially painting. So he has a lot of difficulty with verbal communication, but he is able to indicate that we have an art therapy room, but it's locked when it's not in use. And he's able to indicate to the team that he wants to go into that room, but there's not always someone in the room. So the team decided to install a doorbell on the outside of that door. And when John wants to go into the room, he knows to ring the doorbell and the staff come and respond. And we provide a lot of one-on-one time with John in the art room. So certain staff members have really developed a rapport with him, knowing how to work best. Something like limiting choices on art supplies, something that's really helpful to him versus giving him sort of all of the options in the cabinet. We've been really lucky to have an art therapy intern with us for the time being, and so she's been able to work with him. And he also has a speech language pathologist that he sees at home, who we've been able to collaborate with to create some communication boards and just to kind of work through some of those communication techniques that are best for him. We've had other folks in the program. Trevor, who was quite young, quite fit when he came into our program. He really thrived in the social environment, thrived on having the routine, and he would walk laps around our center, which is set up like a rectangle. But because we're in the DC area, we have a lot of participants in our program who worked for CIA and Secret Service and had other professional roles where they were really trained to be highly observant. This actually could become a trigger for other participants in the program. So our team started working with Trevor at, taking him outside on walks at specific intervals throughout the day, which is really a win-win. He enjoyed that one-on-one time, he enjoyed the fresh air, and it also helped to decrease any agitation among other participants who are in our day program. We have a gentleman who has a fixation on time, and through trial and error, we learned that if his wife needed to have him at our program longer a specific day, it was better to bring him earlier in the morning than to have him stay later in the afternoon. We have an individual with some repetitive behaviors, including, clapping hands really loud or banging on the table. And so by putting a tablecloth on the table where he usually sits, or during musical programs, having him wear some thin gloves so that the clapping is muffled has really been helpful to not become a trigger for other participants in the program. And the last example I'll share is of Karen, who has progressive supranuclear palsy. And we've been able to partner with a home health agency to provide PT and OT services in our center. So she can receive those services while she's with us 5 days a week in our adult day health center. And we really work with the families too to help them understand, how to get therapy orders, what that process looks like and when it's indicated. So we all know that having a diagnosis like FTD doesn't only affect the individual, it's also their family. And so that's something that we at Insight do, and we encourage all of you, is what kinds of supports do those families need? So that could be consultations. At Insight, we have an FTD caregiver support group that meets on Zoom once a month, free and open to the public. We've partnered with a senior living community to offer an aphasia memory cafe, again, open to anyone. And we put together a lot of classes and webinars, both for families and professionals around FTD. And we share resources like AFTD's materials, which has been really, really helpful, especially for those newer families who are coming to us and just really looking for some direction on where to start. So we know every person's different, every family's different. And when a family is facing FTD, this is probably the most challenging time in their life, or at least one of the most challenging. But it can be so helpful to the family to have a supportive team to be there for them. And I found it such an honor in my career to be able to work with these families and to provide, some support, some hope, some help that just takes some of the challenges that they're facing, takes a little bit of that away, provides a little bit of extra support for them, And I know that your setting can do that as well. So with some focused energy, with some time, some dedication, and using the tools that you have available to you, you really can make a difference in the life of someone living with FTD and with their family. So thank you. I had more to say, but I know we have two other excellent panelists, and so I will turn it back to Will to be able to introduce them. Thank you.
So thank you, Lindsay. And I'll just acknowledge that along with the Partners in Care printed resources, we have a library of over 30 recorded webinars that are presentations that have been done over a number of years, some of them specifically about BVFTD or primary progressive aphasia or one of the other FTD disorders. And I thought that was a very important note that Lindsay made, which is it's really key to know what type of FTD disorder and to be providing training on all of the FTD disorders for your staff, because certainly the symptoms and the approaches to care for someone with primary progressive aphasia could be quite different than someone that has a diagnosis of BVFTD, but they're both FTD disorders. So I'm going to move on to our next speaker. Our next speaker is Tim Lindsey. He is an AFTD ambassador living in Bella Vista, Arkansas, and he's been an AFTD volunteer since 2019. Since 2022, he has been a director of operations with Visiting Angels. But prior to that, his previous work includes operations manager and director of operations in home care, co-owner of home care, executive director, regional director, and senior director of operations overseeing memory care facilities. He has a master's degree from the University of Arkansas and is a certified Alzheimer's disease and dementia care trainer. Additionally, Tim served in the U.S. Army for over 20 years. So Tim, thank you for your years of military service, but also your years of service within healthcare, and in particular, your commitment and devotion to caring for those with FTD. So I will turn the platform over to you.
Well, thank you, Will. Appreciate that introduction. Want to thank everybody for the opportunity to address this group regarding this very important topic. So, I think before we really start talking about how we in home care assist our clients that may have FTD, maybe we should just define it, because I think there's a little bit of confusion out there about, what is home care? So before we do that, I guess we should talk about what it's not. So home care is not skilled medical services like your home health services that are providing, a variety of different types of therapies and skilled nursing, in a home care or in a home setting environment or in a facility. But home care is a great option for those who want to age at home versus living in a facility like an assisted living facility or a nursing home. So home care services, they can be provided 24 hours a day, up to 24 hours a day, 7 days a week. And the care typically is going to be one-on-one care, one caregiver with one client. And so a customized plan's developed for the clients and the family, their input when this thing's put into place. And the services are, as far as payer services or payer sources, because I know this is typically a question that comes up for some folks. Many times those services are paid for out of pocket. Long-term care insurance will typically cover some of those services, and some home care agencies do provide services through their state's Medicaid waiver programs. And there are some veterans services out there that could possibly, the individual could possibly be approved for services through the Veterans Administration, and that will tip some of those services, sometimes all, but most of the time some. And so private duty, non-medical home care services are ideal for maintaining independence, assisting with family caregivers, or providing a respite break for the family caregiver. And so home care services may include things like just normal companionship, bathing and hygiene assistance, helping with dressing, meal preparation, light housekeeping, laundry, exercising and walking, and interaction activities for mental stimulation. And so when working with FTD clients in home care, it all starts with the training and education of our staff and determining the needs of the client. And so Lindsey spoke to this a little bit earlier. So when it comes to training and education, I'm going to share some of the tools that we use in my organization that really assist our care teams in this process. But I think it's really important to point out that most home care companies are going to have similar systems in place. They just may be called something a little different. So we currently have a vast library of training resources. It's about 16 hours of training that's dedicated dementia-specific training currently. And our training focuses on topics when it comes to dementia and more specifically FTD, understanding the symptoms of dementia, communication challenges, understanding behaviors, and what we like to call responding to difficult situations. And so we've got several tools available for our care teams to assist them in providing care. One of those tools that we utilize, very similar to what Lindsey mentioned, we call it our life story questionnaire, which is designed to gather social and spiritual information and determine their likes, dislikes, and this have more positive interactions with our clients and better understand their needs and their wants. And as I stated earlier, most home care companies will have something very similar in place to this document and this process. And so when our care teams are preparing to work with a client with FTD in the home care setting, we really emphasize being empathetic as possible when we're having those interactions and seeing the situation from the client's perspective, trying to put ourselves in their place. Being patient with the client during the process it's a key to success in that area. And consistencies of schedules and care are very important. Trying to stay within the same routine for normal activities and attempting to keep consistent care staff is very helpful to the client as well. Modifying the environment to reduce confusion and distractions is also very important. And we really strive to determine what are the unmet needs if we have situations, especially with the behavioral variant of FTD, where we have some situations going on. We know that that's a result of an unmet need. So we really want to try to determine what those are so that we can improve the quality of life of that individual and help reduce any anxiety or distress that they may be experiencing as a result of that. And we really focus on trying to determine what those needs are. We have an acronym that we use. Some of you that are in healthcare may have heard of this before. It's the acronym TIPS with 4 T's on the front. And so, the first T is, it's temperature. Are they too hot or are they too cold? Are they thirsty or are they hungry? Do they need to go to the restroom? Are there some types of toxicity going on within the individual as a result of an adverse reaction to medication, or especially if they've recently received a new medication, a prescription for a new medication? Do they have some sort of an infection, a UTI or the flu or COVID? Are they in pain and they can't communicate that back to us? And are they overstimulated or understimulated? And then the last part of that is, do they just need a little bit of additional social interaction? And so we're really trying to discover those unmet needs so we can address them and hopefully make that situation better. And so when it comes to communication, we communicate with our clients in a way that is most effective for their needs. And this may include using visual cues to augment with that communication. It may include using some communication notebooks or labeled pictures of people or objects if it's necessary and appropriate. And when speaking with our clients, we speak slowly in simple sentences using close-ended questions when it's appropriate to do so. And we use a non-medical supportive approach to care that ties in with our observing and reporting process. We call that stop and watch. It's another acronym. We love acronyms in healthcare, right? And so it's a tool that we utilize with our caregivers to help identify any changes of condition that may be going on that can be utilized to make changes to the care plan. And we pay attention to some small changes like their communication abilities, if they're changing, if they need more help with activities of daily living, and body weight changes, just to name a few things that are encompassed in that stop and watch tool. We also have a hospital to home transitional program that we call Ready, Set, Go Home that focuses upon making changes to the care plan when the client's transitioning back home from a short-term stay in a facility like a hospital or a short-term rehab. And we do this by gathering information from the facility about new or different care needs, including medication changes. And one of the main goals of the program is to help the client safely stay at home and hopefully reduce the possibility of a further readmission with that individual. We also have a palliative care program, and this program provides knowledge, tools, and support. And it also helps to further coach and train our caregivers about the process and what that really means. And of course, the goal is to enhance care services and continue, and to contribute to the continuity of care. So for our clients suffering from distressing symptoms like FTD, by using systems like this program, our caregivers will have a better understanding of palliative care, what it really means. And as most of you know, if you are involved in healthcare or if you're a family member that's been around it, palliative care falls somewhere in the middle of curative care and hospice. And so palliative care helps people manage the physical symptoms and the emotional stressors and focuses on the patient's goals for care, their values, and what's important to them, unlike hospice, which of course focuses on comfort care at the end of life. And so we place a strong focus upon safety in the home to reduce falls, which many times we have with FTD, and reduce the risk of a potential elopement. We use a home safety checklist to assist during the process, as well as a fall prevention tool that we call Safe and Steady. So this process begins just like with many other healthcare related organizations with our initial in-home consultation or assessment, and includes information gathering to fully understand the needs of the client so that we can put together a comprehensive plan to address those care needs and the social interactions. We focus upon activities that the client's interested in and that they're physically and mentally able to accomplish, and activities that bring them joy. Physical exercise, music, and other activities that the person enjoys or finds useful are also very helpful. These activities are often the most effective way to help a person with FTD to maintain a good quality of life. So in summary, as Lindsey mentioned, we also practice person-centered care, not just for dementia clients, but for all of our clients, but especially our folks that do have FTD, which involves tailoring the person's care to their interests, their abilities, history, and their personality. And person-centered care is a philosophy that recognizes the individuals have unique values, personal history, and that each person has an equal right to dignity, respect, and to participate fully in their own environment. I'm Tim Lindsey with Visiting Angels, and I'm also a volunteer ambassador with the AFTD. Thank you.
Thank you, Tim, for talking about home care and how it can best support people with FTD, and also highlighting the importance and value of palliative care, which is an expanding approach to healthcare across our country in a number of communities. Hopefully, many of you have palliative care providers in your community and your region. And there's more information, again, about palliative care and its support of people with FTD on our healthcare professional webpage. So I'm now going to move on to the introduction of our final speaker. And our final speaker is Susan Hirsch, who has worked in the field of gerontology for over 30 years and has a master's degree in psychology, gerontology from Hood College in Frederick, Maryland. She is currently the community engagement manager at Penn State College of Medicine. She specialized in dementia care as an education and dementia specialist and has developed and implemented specialized dementia services and has collaborated on several research studies. She was an advisor for the AFTD's Partners in FTD Care newsletter initiative that I've been mentioning a number of times, and currently serves on the AFTD Education Committee. Sue has joined us. I am going to share my screen and share Sue's slides. So hold on, Sue. I'm going to exit this and pull up this PowerPoint presentation. And hopefully, Sue, you can see your slides.
Yes,
Great.
thank you so much, Will. Thank you.
Sure, and
Thank
I'm going to
you.
go off screen and off microphone, and you'll just let me know when you want me to advance them.
Okay, great. Thank you so much, Will. In 2011, I was the administrator at a memory care community, and we received a call from a husband who was the caregiver for his wife who was diagnosed with FTD. He was no longer able to safely provide care for her due to her increasing obsessive, roaming, and personal care refusal behaviors. And at that time, my team had very minimal experience in providing care for individuals with FTD. I shared the information that her husband and the diagnostic team provided to me with my team, and they were committed to having her join the community. Her husband recommended that we reach out to the association, and we did. And they provided the education and resources that enabled us as a team to provide the specialized, individualized care that she needed in a community setting. Today, I'm going to share 3 best practices that have evolved, and they continue to evolve since the 2011 experience that I shared with you. And also with working and educating professional and family caregivers, caregiving for individuals diagnosed with FTD, and an ongoing, very beneficial relationship with the association. So on the next slide, you will see the 3 best practices. And they include education, information, resources, which I know Lindsey, that is very important. Also conducting a pre-assessment and also an individualized plan of care. And on the next slide, you will see the education, information, resources. And again, that's been emphasized, very important that everyone receives education. And the information I'm going to share with you is based on feedback that I received from both professional and family caregivers. So when we talk about staff, like others have said, it's very important that all staff receive the education, maintenance, housekeeping, dietary, administration, nursing, everyone. And when staff said it's very important to receive training upon hire during the orientation process, but also to receive updates. So example, when a new resident moves in with an FTD diagnosis and we know the specific type, to provide in-services again for the staff. And then what? Staff shared with me that the content, the subject matter that helps them the most in providing care include a definition, an overview, definitely the difference between FTD and Alzheimer's. Many caregivers have experience in providing care with Alzheimer's, but FTD is new. So differentiating the two, also noting that FTD is progressive, the different stages, Noting the different types and approaches is very important. Personal care basics, which I'll describe in a couple minutes. Also, my co-presenters did a great job of talking about person-centered approaches and how very important that is. An overview of medications and also the caregiver challenges. And for family and community, also providing them education, support group, and resources. And as Will said, I'm on the website all the time, the association's website. There is so much good information there. I was very privileged to be part of the partners where we created quarterly newsletters. And there's also resources there. And one resource that I use in every training is called Changes in Behavior Chart. I highly recommend it. It includes the different types of behaviors, also gives great examples and then approaches. It's a great educational tool. And then if an individual has a specific symptom, a specific behavior, there are newsletters there that will help your team. Like if there is a resident who has aggressive behavior, compulsive behavior, sexual behaviors, there's all kinds of newsletters that provide a case study, but also provide what to do about that behavior. And then additional resources, definitely support groups, there's webinars, collateral. If we have a younger individual who moves into a community that has younger children, there's a booklet I use a lot. It's called What About the Kids? It's an excellent booklet, an excellent resource to help the children. Also, there's a video that I show on every training that I present. It's called It Is What It Is. It shows the impact that FTD had on 4 individuals and their families. When I show that to staff, they say it really provides them a realistic, empathetic understanding of the impact. And for families, they share they definitely relate to the families. And it also lets them know they're not alone and there are resources. And that takes us to the next slide. And this is a sample PowerPoint personal care basics that I provide an orientation, but also to use on an individual circumstance, as my co-presenters shared. I can remember one time I was in a community and the staff shared that there was a female resident diagnosed with FTD who was refusing all showers and baths. We scheduled a huddle, we came together, we talked about her past, the resources, her biographies, all that information was very important. And we looked at her routine. And as a team, they developed a plan to help her in addition to the basics we reviewed. We found in the past she preferred a shower. And looking at her lifestyle biography, a couple of the caregivers, they highlighted that she loved going to the spa. So they came up with a wonderful idea and being very creative to recreate a spa experience. And we worked with her husband. He shared that she preferred going to the spa at 2 o'clock. She was early in the disease process, so posting her daily schedule was very helpful to her. So the staff would put 2 p.m. She had a spa appointment. And in the shower room, they made it a spa experience. And again, worked with the husband with this. They would lower the lights, had aromatherapy. Her husband provided her favorite soft music, her favorite terry cloth robe, and then snacks. And what they found by working together and incorporating the husband, person-centered care, very important. She not only did not resist going to the shower room, she actually enjoyed the spa experience. So a great example of the whole team coming together. And then on the next slide, you'll see the second best practice, which is pre-assessment, which again, my co-presenters have shared is very important. A lot of the information that helped in the situation I just described, that was gained on pre-assessment, the biography, context, all that information. But having that information is very important, noting the history of the person, what approaches worked, what behaviors, also looking at the diagnostic process. And if we know the type of FTD, that's also very, very helpful. And what I found in communities, bringing all that information together, meeting with the family, meeting with the team, having really realistic expectations, and really talking about the needs of the person, and then making the decision. Is this community the best placement for the person? If it is, then we go to the next slide. And that's the third best practice. It's developing, creating, and implementing a plan of care for the person and involving everyone. Also talking about expectations. There are 2 e-newsletters that I use all the time, particularly when a new resident moves into a community, and you'll find them on the web. One's fall of 2015, one will shared from summer of 22. And they talk about relocation stress syndrome, which is a nursing diagnosis when somebody moves from maybe a community to another community, home into a community, may have more fear, anxiety, sleep disorders, trouble eating, those types of things. Those articles are phenomenal about describing the relocation stress syndrome, but importantly, they also give great approaches. For example, visitation. Sometimes families ask, should we visit, not visit? There's a wonderful chart that I use. One side, when do you encourage visitation? And another time when you might discourage visitation within resident rights. And how do you share that with the family? Also creating within a community a home-like environment for the person that's safe. It also helps with questions like, do we bring a TV in, not bring a TV in, a telephone, not a telephone? Excellent, excellent resources. Also, my co-presenters talked about activities, very important. You know, communities are social environment. These individuals many times are younger, they're active, and how to engage them in a community setting. There's another e-newsletter that was written in winter of 2013 that I look at and share frequently. It talks about providing group activities for someone with FTD without overwhelming them. And for some people, it's better to provide individualized programming where we look at their past interests. Did they enjoy music, art therapy, low stimulation type of activities? It's a great resource to help that person get engaged into the environment. Also getting the family. I remember a 45-year-old gentleman who moved in. His daughter was in the choir. We had the choir come in. It was one of the few times I actually saw him smile, and it was great. It was a great experience for everyone. Also in the plan of care, we talked about personal care, talking about personal care. My co-presenters talked about the benefit of therapies, very important to involve therapies, talking about behaviors and approaches. And last but not least, communication with everyone. And I find more and more communities, when you come in, they have a display case where you will see collateral that includes different types of dementia, including if the community does provide care for someone with FTD. There's collateral that you can get from the association again. And the collateral is very, very helpful. And those community teams said that they've done that and said it's been very beneficial because it gives everybody education. And it's a good example of the 3 best practices that I shared, because it provides education resources for everyone. It's very proactive because looking at what are the resources that are needed in the community, and then the team has a plan. There is collateral that's available to everyone. Also, I see a lot of communities have speakers that talk about dementia, different types of dementia, including FTD. And then also they will provide knowledgeable individuals, the team members who will provide answers to individual questions. So that's an example of the whole community coming together to provide the best possible care within a community to an individual. And I'd like to thank you very much for the opportunity for me sharing the best practices. Like I said, they continue to evolve. And I hope that they will assist you and your team in providing individualized, specialized care within your communities. And thank you very much. Okay,
Thank
Will?
you, Sue.
Thank you.
And I didn't mean to shut your PowerPoint off
I got
like
you.
that.
No.
I actually clicked on stop sharing inadvertently. So I'm going to invite our other speakers to come back on screen, and you as well, although it seems like you disappeared. And just say a big thank you to all three of you. I think different perspectives on what you shared and how you shared it, but there was also clearly alignment in a lot of areas.
Yes.
And you both spoke to the need for a rich, active, and purposeful engagement for individuals. And I think Tim as well, that's certainly true in home care, in a generally more one-to-one perspective often. And in terms of in facility-based or day programming, the value of being able to pivot or offer different kinds of activities at a single time, an individualized activity as well as a group activity. So I'm sure our audience learned a lot, and unfortunately, we are over time. And so in about 10 minutes, we'll be coming back together for the next plenary. And we have a thank you from our audience. So thank you, all three of you, for joining us. And this session was recorded and will be available on our YouTube channel, which is where all these other videos that have been mentioned are also available. So see you all soon, and thank you to the three of you.
Thank you so much.
Yeah.
Thank you. Thank you.
Bye-bye now.
Bye.